Well, welcome everyone. My name is Sarah Anderson, and I am the Executive Director of the Bay Area Global Health Alliance. Krista Donaldson, that you all probably know very well, serves on our board. And we are just delighted to be co-hosting this event with the Stanford Bayer Center for Biodesign. It's really great to be here, and I don't want to spend too much time, but I just wanted to introduce the Bay Area Global Health Alliance to all of you in case you don't know of us. We started here in Stanford University, so you all are is a member, and so all of you are members. And we would love to engage with you, but the Bay Area Global Health Alliance was started a few years ago, basically to bring together different sectors together to talk about how can we together advance global health equity and innovation. And with that, we're now 85 organizations and companies. About 40% are based here in the Bay Area. So we still have the academics that are based here, but we're based, have many other companies. But what we also are doing is that we're engaging the tech sector with traditional global health stakeholders. And that's what makes us a little bit different, but we serve as a neutral convener to connect people. We broker novel partnerships, and we do communications to amplify the good works of the Stanford Biodesign and Dr. Harris's works. So we'd love to hear more. I left some little cards over there and hope you enjoy this talk. I'm going to now pass it over to Cyan to introduce Dr. Harris. So thank you.
Thank you so much for being here. It's so nice to see some new faces, familiar faces, and to those of you joining online, thank you so much. A quick reminder for those of you who are here in person, could you just switch your phones to silent if possible? For those of you who aren't from the center, if you need the bathroom, the restroom is right door. And there are snacks and water available. There is also a water filter if you need that. We're really glad to see all sorts of people from across campus here, and we hope you enjoy the event. So as Sarah said, my name is Cyan. I am heading up the Equity and Innovation Second Year Fellowship, and together with the team, we are focused on bringing more health equity to Biodesign. Biodesign's new mission is to advance health outcomes and health equity using innovation, translation, policy, and education. And so we are really committed to thinking about how we're going to use innovation for health equity, hence our talk today. I have the privilege of introducing Dr. Matthew Harris today. He's a clinical senior lecturer and honorary NHS consultant in public health medicine from Imperial College London. He's also the director of postgraduate talk programs in the School of Public Health. He is the team lead for innovation and evaluation at the NIHR in Northwest London as part of the Applied Research Collaborative. He's published over 150 articles in global health, revert and frugal innovation, decolonization, and health services research. He's a former US Commonwealth Fund Harkness Fellow, a United Kingdom Government Global Health Advisor, an HIV Technical Advisor in Mozambique, a World Health Organization immunization consultant in Ethiopia, and a family doctor in the Brazilian primary health care system from 1999 to 2003. So as you can see, he has a breadth and a depth of experience, which we are so privileged to have here today. So the format for our talk today is that Dr. Harris is going to be sharing some of his work with slides. And then we're going to have a chance for Q&A, where I encourage you to dig into things that are unfamiliar, things that are familiar, any questions you may have. So with that, I'd like to give a big round of applause and welcome Dr. Matthew Harris.
Thank you ever so much, Cyan, for teeing up this event, and to Sarah and Gordon and everybody here for coming. It's 5 o'clock, it's a late evening, so I really appreciate you coming. It's a great pleasure to be here. Thank you so much. What I'm going to talk about actually is all in my book, which I hope you'll be interested. It's also kind of from a UK perspective. So I'm also interested to know whether any of what I talk about resonates from a US point of view. So just want to caveat that what I'm going to say is grounded in the fact that my experience of this area has arisen from a deep frustration with how things are going in the UK health system, and a continuous clamour for more resources being pumped into our system without a commensurate consideration of actually, can we innovate in a slightly different way? Can we innovate in a way where we're actually driving down costs without scrimping on clinical safety or effectiveness? And at the same time, can we innovate in a way whereby we're actually learning from regions of the world that we've traditionally not heard very much from or not paid attention to? Okay, so that's really where I'm coming in this presentation. I'm going to start with just talking about a few examples, which I think are really exciting examples of healthcare solutions that originated from these regions of the world that actually drive down costs without scrimping on safety or effectiveness. So I'm going to start with that. And then we're going to talk a little bit about some of the barriers and challenges that I think exist, at least in the UK. Interested to know whether it's the same for you here in the US around adopting some of these solutions and what can we then do about that. Okay, so let me start first of all by getting this to work. I could just use that. Maybe. Oh, that's all.
No, try that clicker and check one.
Okay, excellent.
Sorry about that.
No, that's fine. Thank you. I'll start with just a few examples to set the scene, right? This is called the GE Mac 400. I don't know if any of you have heard of it. It's an electrocardiogram machine, so it's a heart monitor essentially. And it replaces, it's an alternative to existing technology that we have in the UK, which are quite sophisticated ECG machines that find in ITU wards or departments. They're quite expensive. They're about £20,000 each. And they have a lot of functionality associated with them that explains the cost. The GE Mac 400 was actually developed in India by a subsidiary of General Electric in order to improve access to ECG readouts and access to cardiological diagnostics in rural communities. And so they essentially made a rugged, portable, lightweight ECG machine, but that actually does an ECG as well as the more sophisticated technology. So exactly the same output, essentially, but at a fraction of the cost. What's interesting is that this technology is now cannibalizing the market here in the United States. The clinicians in outpatient clinics are actually buying this GE Mac 400. It's far more affordable, and it means that you can do an ECG in an outpatient clinic. You don't have to send people to hospital, for example. So it's quite an interesting example of what we call a reverse innovation. I don't know if any of you have heard of that before. Good. Another example is now in the space of orthopedic surgery. In the UK, and maybe here as well, I don't know if any of you are orthopedic surgeons, but at some point in an orthopedic operation, you need to drill a hole into something. Right? It's usually a bone. And that's to put a wire in, or to produce a fracture, or a hip replacement, or whatever it might be. And in the UK, these stainless steel drills at the top there called striker drills, and they're about £30,000 for each one. That's because you can bake them in an oven and it doesn't die, right? It's made of stainless steel, you can autoclave it to sterilize it, obviously that's necessary, but that's actually quite a sophisticated, that's quite an expensive piece of kit. So in Malawi and actually in Uganda, where they didn't have availability of this sort of technology, they took ordinary hardware drills. Some of you may have this at home. I have one, I use it to put up shelves. And they made it fit for purpose for an orthopedic operation. Obviously it needs to be sterile, but what they did was they wrapped it in sterile cloth, or cloth that could be sterilized, so like a surgical gown. Canadian bioengineers actually came and witnessed that practice, and they improved on it, right? So they designed the surgical gown material in a certain kind of way to fashion it into a bag. You can put the drill into the bag, seal it, and it's sterile. No such thing as kind of sterile. It has to be either sterile or not sterile. So it's a sterile encasing of the ordinary hardware drill. And because the drills only cost about £100, you've suddenly got a very affordable piece of surgical technology that does exactly the same thing as the more expensive technology, so at a fraction of the cost. So a study that we did modelled what would we save in the NHS if we swapped out all of the existing technology with this one, and it's like £100 million overnight, right? If you were able to do that, you would save £100 million. At the hospital level, if you use this solution compared to the existing one, you'd save about £200,000 per annum. And that's taking into account all the consumables and everything else. There's quite a lot of nurses when you think about the savings. Yeah. This is now in the neonatal medicine space. And some of you might know that if you're born prematurely, you can be at risk of hypoxic brain damage. And one of the solutions to that is to reduce the body temperature of the baby very quickly, but safely, steadily, but very quickly down to about 34 degrees. And you do that, at least in our countries, with this expensive piece of technology. It's like an incubator machine, servo control device. The details of it in the middle of the table. And it reduces the body temperature safely down to about 34 degrees for like 3 days. And that prevents hypoxic brain damage. Now, in countries that don't have that technology, they've been using ice packs or actual ice. And the problem with that, whilst it reduces the body temperature, it doesn't do it in a very sort of safe way, gradual way. You can burn the skin, you can picture it, right? It's not a sophisticated way of cooling, and therefore less effective. But in India, they developed the mirror cradle device, which is made of phase change material. Doesn't require any electricity. It's just mattresses that you put underneath the baby that sucks the heat out of the baby in a safe and gradual controlled way, reducing the body temperature in exactly the same way as the more sophisticated high-tech cooling devices at a fraction of the cost. So no electricity, fraction of the cost, easy to use. Very interesting, I think, solution. Okay, so this is now in neurosurgery, right? So would you believe you can also innovate in this sort of way? These devices for very delicate, micro dissection techniques with brain surgery, you can imagine, very important, sterile pieces of equipment that we need here. But each one of these tools are about £100, so each one. And Jha, who's a neurosurgeon in India again, realized that you could actually functionally do the micro dissection just as well with stainless steel wire that you just fashion the end of so that you get the different types of functionality that you get with the ordinary equipment. It's sterilizable, stainless steel wire, it's readily available, it's very easy to use, and you get the same level of functionality in reports. So a fraction of the cost again. So I think an interesting solution. Okay, in general surgery, if anybody's had a hernia or one day might need a hernia operation, you treat it with surgical mesh. Yeah, it's like a polyethylene type of mesh. But each one, at least in the UK, is actually quite expensive. It's about £200–300 each. It comes pre-cut, pre-sterilised, pre-packaged, single use only. But it turns out that mosquito nets, when not insecticide treated, are made of exactly the same material. And beginning in India and scaling throughout sub-Saharan Africa, through the efforts of NGOs like Operation Hernia, Hernia International, they're actually using mosquito nets to do complex hernia operations. And when you think about it, a mosquito net is large. You can cut out thousands of appropriately sized bits of mesh to do those operations, and therefore you're improving access to surgical care. And clinical trials have actually compared commercial mesh to mosquito net mesh, and the outcomes are largely identical in terms of infection rates, relapse rates, safety profiles, adverse events, and so on. All right. Okay, in obstetrics, postpartum hemorrhage. Surgical emergency at times, if the medical interventions don't work, but something you can do before you do a hysterectomy is use balloon tamponade devices, such as the ones on the left-hand side, that are commercially available. They cost £200–300 each. Essentially, the catheters inserted into the uterus in this obstetric emergency situation inflate the balloon with saline, and it exerts pressure inside the uterus to stop bleeding. Yeah, very effective. Dr. Saiba Akhtar is a Bangladeshi obstetrician, and she uses just a condom tied to a catheter, urinary catheter. Okay, so that's the picture on the far right. Both of these things are readily available, and they work in exactly the same way as the commercial devices, but cheap as chips, as we say in England, right? So readily available, costs nothing to use. And actually, systematic reviews have shown that studies comparing the Saiba's device with the commercial devices, they're really comparable in terms of outcomes. Okay, so again, an interesting solution. A couple more examples, this time in plastic surgery. I don't know if some of you may have heard of this as well, but tilapia fish is being used in the Brazilian Amazon by Brazilian researchers and plastic surgeons for skin grafts. So it serves two functions. It serves as an occlusive dressing, so basically preventing any infections on the burn, but also serves as a skin graft, because as the skin starts to desiccate over time, new skin grows through it and leads to re-epithelialization in actually a really remarkable short period of time. So studies have shown that using tilapia fish skin is as good as using skin grafts either from a human or from a cadaver, auto skin grafts from the same individual or from pigs, actually performs just as well, right? So and also less pain because you don't need to change the bandages, less infection rates, rapid re-epithelialization, and again, only $11 for an entire course of treatment. So a really interesting solution. The skin grafts that we use in the UK for a piece the size of your iPhone costs £1,000. Okay, and you actually have to keep reapplying. So when you think about it, there's a significant cost saving that we could be looking at here. And then finally, just to make the point that not all solutions from the regions that I'm talking about necessarily are technologies, right? Or at least not gadgets, right? They can also be service improvements, task shifting models. And the friendship bench, some of you may already be familiar with, is being used in the US now and also in the UK as well. They're just grandmothers who are trained in short bursts of cognitive behavior therapy to help women who are at risk of postpartum depression. And studies have shown that actually they're really effective and obviously a lot cheaper than psychiatrists, which take a long time to train. And you might not have many of them and so on and so forth. So a really, again, interesting solution. And these are all, I think, examples of what we would call frugal healthcare solutions, which some of you might be familiar with, particularly from this department. These are ideas, these are technologies or solutions that essentially do more with less for more people, right? They improve access and therefore equity because you can get more people treated because they're more affordable. And they tend to be things that are just simpler in nature, right? So I've given you several examples. These are solutions that maybe have less functionality. They might not be quite so sexy. They might not have so many widgets and gadgets and displays and this and that, but actually you strip out a lot of that functionality that isn't really central to the core function that you want it to do, and you can make a significant saving. It's about repurposing technologies. It's about taking resources that you have around you and adapting them. And that's the idea of frugal healthcare innovation. Okay. So then the question is, why is it so hard? Why do we not know about these oftentimes, right? Why do we not pay attention, perhaps, to the regions of the world that are doing these sorts of innovations, that are coming up with these sorts of ideas, that are improvising, that are coming up with solutions that actually seem to be just as effective as what we're currently using where we are? And I'm going to make the point that I think it's because we just don't look to those sorts of regions of the world. Okay. So I go into a bit more detail in the book, but I just want to tease out three, I think, interesting case studies, if you like, about how that's the case. How do we know that that's the case? So this is the first example. This is the Wanless report, which was a really significant, important report in our NHS, which called for a significantly increased investment in technology at the time, which was published in 2002. And I looked through this report and noticed that actually only a handful of countries are used in that report to make comparisons with. Okay, it's France, Germany, Netherlands, Sweden, Australia, Canada, New Zealand. Okay, those are the only countries that were mentioned throughout the report. This is a table from the US Commonwealth Fund's research that they publish every couple of years called Mirror Mirror on the Wall, that they do case study comparisons between different types of health systems. And the important thing to note here is that it's the same sorts of countries, right? It's UK, US, Canada, Australia, New Zealand, and so on and so forth. And then another pattern here. Again, these are just three examples. I'm sure they'll probably be the same in most other policy papers. The NHS long-term plan, again, a really important policy paper for us in the UK. Same sorts of countries, again, that are highlighted in terms of comparison, right? The rationale for that. But I just want to tease out a few things that are, I think, interesting here, that we can learn from the technique of textual analysis. I don't know if anybody's familiar with that, which is about looking at texts, essentially, like these policy documents, and ask, these represent something important within our society, right? So how can we analyze them critically to work out what is it that they're saying that reveals something about the way we think and behave in society? So a couple of techniques here are things called structured absences and exnomination. And the point I want to make is that by looking at these reports, you get the idea that only certain countries are ever included in terms of international comparisons, particularly for UK audiences, and I think possibly also the US. It's always the usual suspects, and it doesn't need to be explained. It just is. Yeah, so that's what X nomination means. It just kind of is. It doesn't need to be justified. And I want to just make it's a silly example, but just bring it to your attention, just to round the point home. There's a lot in society that we do that is taken for granted. We don't know the reasons why we do it. We just do it. For example, if ever you've seen a watch advert in a glossy magazine or a bus stop or on the metro or whatever it might be, I can almost guarantee that it will show the time 8 minutes past 10. Okay? I can almost guarantee it. Like I really find it hard to actually spot a watch advert that doesn't show 8 or maybe 9 minutes past 10. Okay? And there's no reason, there's no actual clear reason for it. I've actually looked at photographers' literature, right? So advertising literature about, you know, why is it that it's always 8 minutes past 10? And then it's nowhere to be found. There's no rule. There's no guidance. There's no thing that says when you take a photo of a watch, you must show 8 minutes past 10. Lots of other information about the lighting and the perspective and the shape and the size and how you should, but no one has ever said, and it must be 8 minutes past 10. Okay? In any of the guidance. So I think that's quite interesting. And it sort of resonates with what I'm talking about in terms of the countries that we choose to pay attention to. So there are some theories that abound about this. Some people say, I've actually heard somebody say that this is the time that Nostradamus predicted that the Earth was going to be invaded by aliens. Okay, I'm not sure that's evidence-based. Other people have argued, also thinking about this question, that it must be because it looks like a tick, and you know, therefore, with the hands, it's positive. It sort of signals positivity, tick shape. Other people have said it's because you can see the logo at the 12 o'clock positions. And so from a branding point of view, that's a good way to advertise your watches. That's getting in the way. But then I noticed that actually why would you so we continue to behave because unthinkingly we will still use the same time unthinkingly. And this was I took the other day in an Apple store, and okay, it's 9 minutes past 10, but you know, it's the same sort of principle, right? The adverts just somehow converge to just do the same thing. And that's the point I'm trying to make here, is that when you look at these policy documents, there's something unthinking, just taken for granted about the countries that we pay attention to. In a similar sort of way. That's how things seem to operate in society. So we can do a commutation test, which is a third technique in textual analysis, to just sort of see just how strange it is, right? What you can do is you can look at the logic that they provide in terms of which countries have been chosen in comparison, and just flip it and see if it feels weird, right? So let me take you through the examples. We go back to the Wanderless report. It's the only logic that I could find in the report that explains why these countries have been chosen for comparison is that they had broadly similar levels of income per head of population. And that felt, when you read it, that seems like a sensible explanation. But at the time of publishing, the Faroe Islands, Greenland, Guam, and Puerto Rico also had similar levels of income per head of population, but those weren't chosen to be included. So do you see what I mean? And if they had been, you'd probably think it would be weird because it's not done, okay, or because it wasn't adherent to their logic. Another example, back on the Commonwealth Fund report. Again, the only logic that I could find in the report that justified why these countries were chosen was this: the dollar spend on health per capita, but Cuba had similar levels, and the percentage GDP per capita on health. But Uruguay, Suriname, South Africa, and Sierra Leone, at the time of publishing, also had similar levels. But it would have felt strange to have compared to those countries, I think, because we're not used to it. And then finally, the NHS long-term plan, same sort of thing. The only logic I could find that it justified, explained why the UK was compared with Germany on this issue of leg amputation rates was because they had twice the rate as the UK. And then when you read that, apparently that was the only logic that they had. But KwaZulu-Natal at the time of publishing also had twice the rate, but that wasn't used as the comparator. Do you see what I mean? So the commutation test is quite helpful because it throws into relief. It changes the background, right? The relief and the background, and you start to see things just taken for granted norms that you don't see otherwise. So that's quite helpful, I think, little mind exercise. When you ask people though, why do you look to those countries? So qualitative. It's quite interesting. We published a paper a few years ago that asked US policy researchers and innovators, which countries do they pay attention to most for inspiration and innovation? Where do they think innovation comes from and why? And we got these sorts of answers. Well, we would look to Canada. Why? Well, it feels like the same. It feels similar to us. The schools probably are different, the education system's probably a bit comparable, and so on. Which is interesting, because when it comes to healthcare innovation, the fact that schools might or might not be similar is fairly tangential, I think, to what matters where the rubber hits the road in terms of innovation, right? That's one domain only. So really what's happening here is we're using a heuristic. We're using a mental shortcut to make a snap judgment about one country as being more similar to another. I just want to highlight this research that was done published in JAMA in 2018 that shows something I think that runs counter to that idea. This was a paper that just looked at the level of investment in different health systems around the world and their structural characteristics, like population dynamics, workforce characteristics, the health system characteristics. Two things of note. The first is that the paper still only chooses the same countries that we already talked about, right, out of interest. They could have chosen others, but there's still it's the Swedens, the Australias, the New Zealands, the Englands, and so on. But the other really important, I think, feature here is that there is no discernible trend whatsoever that you could argue that one country is in fact more similar or not to another. Yeah, all countries are different. It might seem like an obvious point, but all countries are different, and they are equally different to each other. There is no way that you can say that the US is more similar to Canada, because it will be similar on one dimension, but not on another. Do you follow? So this is the issue across all sorts of different domains. So really what we're doing here is making just an assumption. We're making an assumption. It's a lazy sort of mental shortcut that the Canada and the US, somehow they're part of the same league. That the UK, Germany, France, New Zealand, Australia, they kind of form part of the same league. And there's a logic, therefore, to do that. And we do it unthinkingly. And I think this happens because there's a very clear core and there's a very clear periphery in global health. This is a cartogram that shows, by the size of the country, the amount of research from that country that is consumed globally. So you can see very clearly here that actually countries like the United States and Canada and the European countries, they predominate in terms of the number of citations that researchers from these countries have. Yeah. And there are all sorts of obvious reasons why this is the case, right? The distribution of resources globally is inequitable, right? Our countries have lion's share of resource, and we can therefore produce more research. And you could argue, of course, that that research just simply might be better. It just might be better quality. You could argue that, and that explains why it's consumed. But you've also got to acknowledge that it's published in English. And so therefore South America and countries in Africa and Southeast Asia will be inherently disadvantaged. That the publication costs are really expensive, that the headquarters of international journals that are highly cited are in these countries, right? So network effects immediately will have an important role to play in creating and perpetuating this core and periphery. It's not to say that these countries aren't producing excellent research. We're just not hearing about it. So essentially what this is showing is we're living in an echo chamber, right? A research echo chamber globally that tells us that really the only research that matters is from these countries. And that's the problem. So if we circle back to the solutions that these countries are coming up with, we're just not paying attention. We're just not paying attention to. And I think so deeply entrenched is this issue. When you think about the word that we give to adopting an innovation from a low-income country, reverse innovation, think about how pejorative that is, right? It's innovation only flows from the global south, global north to global south. When it happens the other way around, that's in reverse. So it's really actually perpetuating this entrenched dynamic, I think, in the terminology, and language is important. Yeah. So I had an experience for several years working as a GP in Brazil, in the northeast of Brazil. I had 5,000 patients in my community, and I was a single-handed GP. I had community health workers in my team before, and each one visited. They had a geography of their own called a microarea. of about 150 households. They would visit every single household once per month without fail. And this model, essentially in Brazil, has scaled throughout the entire country in the last 30 years. And there's an army of community health workers all operating in the same way. Okay? They provide comprehensive health and social care advice and support to every household in the community. It's integrated into primary care. These are lay people, but they're trained and supported and paid full time. And it's eminently scalable. There's now 260 or so thousand community health workers across the entire country. They've seen significant population health benefits from this model. And when I returned in 2004 from working in Brazil, looking at the NHS and what was happening in the NHS, I could see immediately that actually this model would really be of benefit to the NHS, significant, right? It would help with widening and entrenched health inequities without going into the system that we have in place at the moment, but it would help with the workforce crisis. It would help with prevention, help with improving access to care and services, which is in fact, despite maybe how you perceive the NHS to be, is extremely fragmented and expensive and difficult to access the care. But when I went speaking to chief executives of hospitals and trusts and Public Health England at the time and the NHS England and even ministers of health in our government about this, trying to explain this is a system that's scalable, it's worked in Brazil, we need to be paying attention to it. All I got was prejudice, yeah? Like quite frank prejudice. It's like, well, we're not used to paying attention to Brazil. Brazil isn't the kind of country that we would want to pay attention to. Does it even have a health system at all? And this time and time again I would battle up against this very knee-jerk reaction with senior officials who should know better, right? Who should be thinking about evidence and global learning. So they just couldn't get around the idea of learning from Brazil. And it's taken, as a result, far longer for us to actually implement this innovation in the UK than it should have done. It was really only COVID that created the burning platform for policymakers in the UK to actually take this seriously. But now, having taken it seriously, in the last 2 years alone, we're now seeing the community health worker role throughout the entire country. It's been mentioned in our world, the full stocktake report in 2022 is a big deal about the future of primary care. It was mentioned in a recent House of Lords debate and also a recent House of Lords inquiry into the future of primary care, in just the last 18 months. So it just goes to show that when something fits, when they're ready to actually adopt something, it can really take hold. It should have happened 17 years ago. That's the problem. Okay, this is all well and good, but now let's talk about how do you measure it, right? How do you, this is sort of what I presented here as sort of circumstantial. Yeah, this is circumstantial evidence that there's a problem, we need to do something about it. But I'd like to just spend a moment talking about that we can actually prove that it's a problem, right? Have you heard of implicit association tests? Have you done them online where you press buttons really quickly and work out your unconscious biases? So we adapted the IAT platform to look at two different categories, whether people associate high-income countries or low-income countries with good research or bad research. Okay. And what we found, and this is results from Imperial College faculty, that on average, because the normal distribution is skewed to the right, actually on average, scholars, researchers within Imperial College have latent associations that good research comes from high-income countries and bad research comes from low-income countries. So does that manifest in practice? We conducted, bear with me, a within individual, randomized, controlled, blinded, crossover design study. Okay? It's like the strongest methodology you can have, right? Where we asked English clinicians to rate online research abstracts. And we gave them the content of the research abstract as it appears in PubMed. And we asked them to rate it against 3 criteria. What's the strength of the evidence in that research abstract? How relevant is it to them? Because of course it might be differently relevant to different people. And how likely would they recommend it to a colleague? And all their answers would be different from each other, of course, because it's a personal experience about reading that research. But what you wouldn't expect is for those answers to change the second time round, because the content didn't change. The only thing we changed was where it was from. We didn't tell them what we were looking for, but we changed the author affiliation of the abstracts from high-income country to low-income country second time round, or vice versa. Yeah. all things being equal, same person rating the same abstract the second time round, changing nothing in the content apart from who wrote it, you'd expect there to be no difference in the evaluation. Correct? Incorrect. What we found was actually when it was listed as coming from a high-income country, they rated it significantly better than when that same content came from a low-income country. So the point I'm trying to make here is that actually it matters in practice. We're not very scientific when it comes to rating science. And we proved that in a very scientific way. So that I think is an issue. Is it racism? That's a hard question to answer because you're talking about people reading a research abstract and then rating it worse because it comes from a country in Africa, let's say. Is that racist? It's difficult to answer that because you're not necessarily thinking about the people and their skin color or their race at that time. So Victor Ray, I don't know if you're familiar, proposed a really interesting integrating theory of racialized organizations, where we can actually think about organizations in a racial way as either being black or white. Yeah, we can think of them as being black or white in the same way you can think about black banks or ethnic restaurants. You attribute race to an organization. Whoever works in it, white or black, whatever race, you attribute it to the organization. And he does that by integrating theories of organizational behavior with theories of race, yeah, which haven't really been done before. So Nature, for example, you've heard of Nature, the journal, actually refers to themselves as one of the white institutions. And they do that because white meaning not everybody in there is white, but we're mainstream. We're part of the orthodoxy, part of the mainstream episteme. Okay? So essentially, what's happening when people rate abstracts worse when they come from the University of Mzuzu or the University of Addis Ababa, they're thinking of them, maybe not knowingly, but they're thinking of these organizations as not being white. They're not part of the white mainstream, Eurocentric orthodoxy. And we know that is rooted in the same sorts of issues that racism is rooted in, right? It's rooted in Eurocentric, white Eurocentric ideologies or logics or worldviews. And modern medicine was created at the same time as colonial expansion was happening around the world, European projects of colonial extractivism and taking over other countries. It's simply the logic of modern medicine is grounded in this idea of modernity itself. And modernity is grounded in this idea of Europe being more advanced and European countries and white countries at that being more advanced, although it's not true, but being more advanced than other countries. So that's the logic that gave permission to colonize. That's the logic that gave the permission to colonize. And medicine is grounded in, biomedicine is grounded in that logic still. Okay, so you can begin to see how it translates that logic, that worldview, that perspective can translate into very simple things like where are we going to pay attention to in terms of where we source innovations? Because these regions in the world just are simply not being looked at. You know, the way that we represent global health and development, I don't think helps. Okay, these are perspectives, worldviews, stereotypes that I think filter through from the mainstream into our subconscious, and we perpetuate exactly the same dependency relationships that I've been describing. And you can actually trace some of these things in any paper that you read, right? And that's what I urge you to do, actually, is to try and identify some of these logics. So, for example, this is the conclusion from a New England Journal of Medicine paper that was a clinical trial comparing commercial mesh with mosquito net mesh. And their outcomes were the mosquito net does really well, and that's actually exactly the same, you know, outcomes as with the commercial mesh. But their conclusion was that it should therefore be used in low resource settings. Okay, so you can, if you're attuned to it, you can spot those sorts of assumptions. And I call them like the us and them assumption. Right? It's all grounded in coloniality, and it's all basically saying this is a cheap solution, so it should be for poor people. That's really as simple as that. They didn't in the article argue we should look at it being used in the US or in the UK. It might not be possible, we should at least look at it. They just jumped straight to that conclusion, that it should therefore be it's a really great idea for poor people, right? But it should really be considered in any context when you think about it. And it can work both ways. So this is a conclusion from the paper that Brazilian researchers did about the Nile tilapia fish skin. And actually their conclusions were the same. They found that it works really well compared to other alternatives. And so therefore we should be using it in poor countries, right? So that logic is also deeply entrenched in the minds, I think, of global South clinicians and entrepreneurs. This idea that what we come up with is good for poor people, but we shouldn't impose it on rich countries because they do things properly. That makes sense. And that I think is a deeply entrenched logic also rooted in coloniality. And this is another example from papers around the balloon tamponade device. Okay, exactly the same outcomes. It should be for resourceful settings. But I would argue that if it's got exactly the same outcomes at lower cost, it should be used everywhere, or at least try to use it everywhere. But then there's a question around attribution, and I just want to spend a moment talking about this because I think, again, the power dynamics that we see in global health really speak to this issue as well. We often find that the ingenuity of global South researchers and clinicians kind of gets erased. Yeah, it doesn't get counted in the same sort of way. That attribution, that credit isn't given in the same sort of way. So in all the papers that refer to Saïba Akhtar's method for postpartum hemorrhage, it's never referred to as Saïba's method, even though she patented it as a method and has always referred to it as Saïba's method in her articles. In all the other articles, it's just referred to as a condom catheter device, all right? And I just think that's worth paying attention to. Why is that? Because actually in surgery, we don't shy away from eponymous names or technologies, right? In fact, we love them. In fact, there's the Blakemore tube, the Foley catheter, the Chamberlain forceps, the Leverett forceps, the Keeland forceps, the Fannin steel incision. But Saïba's method is just a condom tied to a catheter. That's all it is. We don't need to give that a name. Do you see my point? I feel that is emblematic of some important power imbalance in global health innovation that we need to actually call out. Why is that happening? But the other thing is, if you trace, and the book goes into this in more detail, if you trace the journey of this innovation, it's quite interesting. Saïba Akhtar actually, it's not an improvisation because they can't afford balloon tamponade devices that are commercially available. It's not that. Saïba Akhtar came up with the condom catheter device before the balloon tamponades were commercially available. The balloon tamponade devices are overly engineered alternatives that have therefore become more expensive than what was originally conceived, okay? And what's even more interesting is that the Gates Foundation are now funding efforts to sell balloon catheter devices for $5 each back to clinicians in Bangladesh, where they just use a condom and the catheters to the same effect, for free. Do you see my point? So that it feels like there's an interesting dynamic happening in global health there that gives that space and permission to do. Last two slides, I think. Last couple of slides. The first is, what do we then do about it? I think you can.
Computer's about to shut down.
Okay. Okay. I'll keep going. Yeah, going. Nothing to see now. I think there are soft reform as Andreotti talked about, and radical reform approaches to this. And the soft reform is kind of around EDI, right? Or do you call it DEI? Which is all about inclusivity. It's about let's be more purposeful about including the research from the global South. Let's be more proactive about it. Let's go find more research, bring it into the mainstream. But that's still not changing the mainstream. We're just being more inclusive about other people's work and paying attention to it. It's a start. And one of the things we've done at Imperial College, which I think is quite interesting, is that we pay attention to the hidden curriculum in the way we teach global health, right? So we discovered that in our Masters of Public Health programs, the literature that we teach from all came from the US and the UK, 95% from the US and the UK. So what's that telling our students? That's just perpetuating the same thing we already know, which is the research that matters comes from the UK and the US. So we developed a platform whereby you can convert reading lists into machine readable code, which you can then draw down the author affiliations into their geolocations from the Web of Science at pace and scale So you can then, across an entire curriculum of a university, you can actually plot where we're teaching from in real time, like at a glance. And that's otherwise would take months and months and months to do, to figure out where you're teaching from. We know what we teach, we don't necessarily know where we're teaching from. So this helps. And we think that this is a useful point of departure for educators to start asking questions about, am I surprised that I'm only teaching from the US for this topic that I'm teaching? Should I be more intentional about teaching from other regions in the world, and how should I go about that? We're not asking people to tokenistically bring research in if it's not appropriate, but to really start asking those questions. Then more in the sort of radical reform space around reciprocal innovation. This is really about asking how can we do global health in a more purposeful way that is balanced. We're addressing the power imbalances between global south and global north partners, giving each other space to actually innovate together, co-develop, be reciprocal, mutually beneficial around how we develop ideas. How can we do international partnerships where we are thinking about the problems we have as well as what we're going to actually support others to do? And we developed a toolkit for the international health partnerships that we have in the NHS that speaks to this. And then when you think about the actual clinical interaction, it's about, can you apply a decolonial lens to how we interact even with our patients? And that's about understanding that biomedical hegemony, which is fraught with all the problems I've just talked about, rooted in colonialism and so on. And some would argue epistemic violence against indigenous communities. It's asking, that is just one perspective, right? Can we also include other perspectives, not just the biomedical ones? Can we also be more inclusive of indigenous knowledges, employing aspects of what we call cultural safety, understanding where the patient's coming from in all of their guises in terms of their histories, in order to have an elevated level of, if you like, consciousness about what's suitable for that patient care, and not just rooted in the biomedical paradigm, which we've discussed was very skewed. Final slide. This is just, I think, a positive example. Colleagues of Sion and Mai Sabati pointed this out, of a new frugal innovation that you might be interested in. It's actually homegrown here in the US, but has been tried and tested in a variety of low-middle income countries. And it is the Hyperfine Swoop, which is a frugal MRI scanner. Don't know if you've heard of it, but it's portable. It's really much, much cheaper than traditional MRI scanners. You can take it to the patient's bedside, and it only uses the same amount of electricity as a phone, right? So a really interesting new frugal innovation appearing in our landscape. And just to say, if you want to know more, then I've got a few copies of the book, and I hope it's helpful. Thank you.
Thank you.